Great. Hey, everybody, it's Ed O'Keefe, and welcome to the Ed O'Keefe Show. I have a very special guest, Dr. Bruce Patterson, that I am absolutely committed to making sure that every household, every school, every doctor's office finds out about Dr. Bruce and what his team's doing at IncellDx. I want to ramble for about a minute and a half to give Keegan's background, just so everybody knows. The reason why I asked Dr. Bruce to come on the show is because my wife and I, we have 7 kids. Keegan is our 13-year-old, actually just turned 14. And in October of 2020, got COVID and strep the same exact time. And kind of did fine for like the first couple of weeks. And then on November 3rd, when she was supposed to go back to school, her head hurt, her brain was foggy, she couldn't function. And that was the beginning of something that we now know as long haulers COVID. But in that time, we took a kid that was super vibrant, super active, excellent athlete, happy, smiley. And within a matter of weeks, and then over the next, year and a half, we had a kid that was, you think she had mono 24/7. I like to say it was almost like having a kid with post-concussion syndrome because her brain just wasn't functioning. And then just to give the 30-second version for all our listeners and to get Dr. Bruce in this conversation is we found 4 months later that she also either the COVID instigated dormant Lyme in her body, or somehow coincidentally she was bitten by a tick or something like that around that same time. So then we started going down the trail of helping her with Lyme for about 7-8 months. And our Lyme doctor then said, you got to reach out to IncellDx and get the labs done at Dr. Patterson, which is something we're going to talk about today, because just to kind of give the before and after, just so everyone understands, our daughter was being homeschooled, but barely functioning mentally on be able to do any work, wasn't able to go to school, barely able to do any physical activity, to now we're about 8 weeks after initial treatments with Dr. Bruce Patterson. She's back playing sports. Her smile's back. We still have a ways to go from getting her back to 100%, but it's been a life-changing experience. And so first of all, I want to say thanks, Dr. Bruce, and for all you're doing, and welcome to the show.
No, it's my pleasure. And, this is not a unfamiliar story. I especially feel for the kids because it's so dramatic, as you mentioned, Ed. They can't function at school. They can't, their attention span is affected. They can't participate in sports. It's really, you see it in the kids because their whole life is turned upside down. And, adults, it's like, I have fatigue and, and many other symptoms. And I'm not minimizing that, but it's just so dramatic when you see these kids who are so vibrant at that age, and all of a sudden they're, sofa bound. And, and I think with Delta affecting kids and Omicron affecting everybody and their brother, we have seen a huge increase in the amount of long COVID in children.
So today I want to talk about, I want to address the three kind of main issues of long haul COVID, acute COVID, because acute COVID, the majority of the population understands, like, just it's impacted all of us. I still try and explain long haul COVID to people, and they still look at me like I'm crazy. And then when I explain, in my perception, the next epidemic along with long haul COVID is going to be vaccine long haul COVID. So I want to go into that. But do you mind sharing just briefly, just because of the scrutiny amongst our medical professionals who are teaching or educating or intervening, just a little bit about your background, how you kind of got to within IncellDx and kind of went down this timeline, if you don't mind.
No, absolutely, because I think it's important. I mean, I was trained at Northwestern. I was trained as a pathologist and then did a postdoc in virology, which was the late 80s, early 90s. I started working on HIV, the most complicated disease until COVID came around, and spent my life doing viral pathogenesis, and I think that's a really important aspect. This is about my fourth pandemic. I'm using strategies that we addressed, through these other pandemics, and I think it's really important to set that out because, there's been, these ridiculous articles written about us that we're just some doc in a box, throwing a towel against the wall and seeing what will stick, and that's absolutely the furthest thing from the truth. I've published over 150 manuscripts on viral pathology. I'm one of them. I'm one of the academics. I just happen to be running a company right now. So what we sought out to do from the first, so I was in China in January 2020, the first week, and talking about some new immune profiling diagnostics for CAR T or cancer therapy, when somebody mentioned to me that there was this immune virus. And I said, what's an immune virus? They all kind of affect the immune system. They said, no, this is really bad. And so I saw some of the early data, and obviously it was early kind of cytokine storm data. I said, wow, this is chaotic and absolutely crazy, and obviously very focused on the innate immune system because we had never seen this virus. People had never seen this virus before, their bodies, and so they had no immunologic memory. So it was a problem from the start. And I said, really, the only way to attack this is how we attack cancer. Cancer is all about precision medicine, where you don't get a cancer drug until you get a diagnostic that says you're going to respond to the cancer drug, right? Because obviously cancer is very, very complicated. Well, SARS-CoV-2, acute and long COVID, are equally as complicated. And the fact that we're not using precision diagnostics to tell us what to do, I think is one of the biggest problems in managing both acute and long COVID. And that's why we sought out, to look at hundreds and hundreds of biomarkers during acute COVID. And then obviously we went on to look at, hundreds and hundreds of biomarkers in long COVID. And then what we did was used AI to say, what's going on here? And it was the summer of 2020 when we first discovered and reported that, hey, these patients have long COVID. And, oh, by the way, it's very, very different immunologically than acute COVID through our algorithms, right? And just telling long COVID patients that, you know what, you have something real, and you have something that's abnormal. And this is not sort of, extended version acute COVID, I think was half the battle, because they were being ignored, ghosted, told that they had mental illness, PTSD, all of this stuff. And the reality was they had something that was significantly abnormal and debilitating. So that was really the start of everything. And we went on from there to say, well, it looks like this is vascular inflammation. Then we asked the question of ourselves, why is there vascular inflammation? It's because there's persistent carrying of the SARS-CoV antigen for 15, 17 months, maybe even 2 years in these long-lived immune cells. And that's continuously stimulating the immune response and causing, obviously, these symptoms. So, and we've published 4 or 5 papers on this, including an outcome paper on our treatment just recently. So, it's not as if we're doing things in a vacuum and not putting our data out for peer review. And now we have, I think, 4 peer-reviewed articles and 1 in the process of peer review. And there'll be many more this year.
Yeah, it's so interesting, which we'll get to in a moment, on just how the correlation between what you're finding with how you're mapping this out objectively using biomarkers, and how you're finding solutions, or how the body's mapping out similar to like where it could have the same mechanism of action as like Lyme disease or even all these autoimmune diseases, which we can, I don't want to go, I kind of actually want to define long haul COVID first for everybody. But what I want to share with you is, as a parent going through like what I would consider like the dark night of the soul, or like you feel like you're going through hell because you're trying everything. You're talking to all these accredited doctors at these hospitals in Chicago, and people are looking at you like, well, she needs more water. And we're like, like, are you freaking kidding me? And when people say don't question things and don't do your research, I'm amazed, because if we did, we would have never found you. But the one thing I will say is, I remember emailing Ben Greenfield, who's a friend of mine, saying like, I just wish there was some kind of objective data that we could know, like if while we were giving her every supplement and doing all these alternative protocols. But in fact, we were guessing the majority of the time, and you kind of solved that. So do you mind kind of just defining what long haul COVID is and the difference between acute and post-vaccine long haul COVID, just for our listeners? And
this is actually a talk I gave at the big post-infectious immunology conference a couple of weeks ago, where we actually rolled out some new bioinformatics, new AI, because as you know, the symptoms in long COVID, post-Lyme, ME/CFS, fibromyalgia, and now post-vaccination long haulers.
Can you say what ME/CFS is, just for everybody?
Chronic fatigue syndrome. And post-vaccination long haulers is almost identical. In fact, we're sending a new paper in where we use a cytokine hub strategy to define each of those and classify those, right? Because I think one of the big problems going on right now in the space is everybody's lumping all that together. I mean, your daughter's a perfect example, right? You think they have pure long COVID, and then you find out after interview or telemedicine or something, oh, by the way, I had Lyme 3 years ago. Oh, by the way, I had a really bad case of mono 5 years ago, and I have EBV. Oh, by the way, I have CMV from when I was pregnant. That's what I called at the conference PASC plus. So there's PASC, which is long COVID, and then there's what I call PASC plus, which is this intermingling of these other elements: Lyme, chronic fatigue, the chronic herpes family viruses, not herpes simplex per se, but there's a tremendous intermingling, and all of that has to be taken into account when you're looking at all these different diseases. So we developed a new classification scheme that we're about to submit for publication, and it presented at this conference, where through these biomarkers and different combinations of these biomarkers, we're able to say, is this pure PASC? Is this pure chronic fatigue? Is this pure post-Lyme? Is this pure post-vaccination? Because that is absolutely critical. Even though we have a set of drugs that works very well on all four of those, there are things that we need to add. So for instance, if it's chronic fatigue and they have active EBV, we'll treat their immune system with our approach, but we'll also give them antivirals, Valtrex, et cetera. And we've done that a lot and seen really great response in the ME/CFS population. And that's the other thing. There was a paper that came out recently on predicting long COVID in somebody who is acute, and included obesity and type 2 diabetes. But the thing that tipped me off was they included EBV. And to me, that said, okay, you just predicted ME/CFS exacerbation, not long COVID, or not pure long COVID. Because I'll tell you what we found and published in acute COVID is that patients who have acute COVID have extremely low CD8 T cells. What does that mean? Well, we all heard about CD4 T cells during the AIDS epidemic, and when they became low, they were susceptible to opportunistic infections. Yeah, I would say in acute COVID, there were some cases where the levels of CD8, and CD4 and CD8 work together. They're extremely important as part of the cellular immunity, and they work together to fight off cancer. They work together to fight off other viral infections. They work to fight off intracellular bacteria, and so they're critical as part of our ongoing immune surveillance and immune system. So we know in AIDS, the CD4s went down and it was a problem. Well, what people aren't realizing is the CD8s are significantly down in acute COVID. And in 25%, the long haulers, they still have low CD8 counts, which makes them susceptible to reactivation of herpes viral family, Epstein-Barr, CMV, herpes simplex, HHV6, varicella, which causes shingles. So they're not recognizing that.
Can I interrupt you right there? I think that's so important for people to understand because we're moving fast, and Nola and I spend like every day re-listening to you, Dr. Bean, Dr. Osgood. Like we feel like I got my nursing degree. Actually, it's funny. I never went into nursing, but my favorite class was pathophysiology, and I feel like our kitchen is just pathophysiology all day long. But what I hear, like we hear this daily now, like we'll be at a gym for volleyball or whatever, and they'll be like, "Yeah, I got COVID. Now I have shingles," and I'm like, "Oh, dude, do you realize what's going on right now?" They're like, "No, I have no idea." Or I had COVID, and now my resting heart rate's 100. Or my head hurts, or I have the smell, or I have fibromyalgia symptoms. I don't want to derail you, but it's kind of, can you go along that of why that's happening? Or I know you're talking.
I mean, you're not derailing it at all. I mean, these observations are critical because this is exactly what's happening. The problem is, from a medical standpoint, is doctors are just lumping all these together, symptom-wise. So if you have POTS or high heart rate, you go to a cardiologist. If you have dysautonomia, neurologic symptoms, you go to a neurologist. If you have shortness of breath, you go to a pulmonologist. When in fact, at the end of the day, it's all inflammation. And once you relieve the inflammation, these correct themselves. For instance, like POTS. It's caused by the vasodilatation. When these inflammatory monocytes bind to the blood vessels, it causes vasodilatation or enlarged blood vessels. And that's in the brain, it's all over the body. What that does is it drops your blood pressure. You drop your blood pressure, you increase your heart rate. So it's your body doing what it's supposed to be doing, but it's doing that because of the inflammation. Okay. And when you correct it, like we have in our new paper, we used 5 accepted symptom scales that the NIH uses, clinical trials uses, and we treated patients with Maraviroc and statins for 6 to 12 weeks. And then every single one of the symptom scores decreased in this cohort of about 20 patients with pure PASC. And they are all statistically significant. But what our statisticians did is they also related the improvement in the symptom scores with cytokine improvement. So a lot of people say, oh, our test isn't validated. Well, you know what? Number one, it has been validated technically at 3 labs around the world and reference labs. And also this paper validates it clinically, meaning I know for a fact from this data that TNF alpha and interleukin 2 are the 2 cytokines that are driving fatigue. So, and in fact, the p-value on the TNF alpha is 10 to the minus 5th, which is ridiculously powerful. So the correlation between these cytokines and symptoms, we know that if we target the cytokines with drugs that are already FDA approved, improve the cytokine profile or the biomarkers, we know the symptoms are going to follow. And that's the hallmark of our program, is using the data to decide what drugs to recommend to physicians. We don't prescribe drugs. We don't do the testing. So that's the other big misnomer that's been drawn by various rags. But we that's the data that we use to say, from our bioinformatics and AI, this is what drugs this patient will respond to. So
Yeah.
our approach.
So interesting. Like, so Noel and I were talking before I jumped on just to kind of get a timeline for us. We'd seen the cardiologist, we saw infectious disease, we saw rheumatologist. We, are in what I really like about how you and how your other doctors talk about why I want to talk briefly about this, but I want to go too down this rabbit hole is like, we're trained as parents or as people to go to your general physician to get support. And I think you guys have done a nice job of not being critical because the whole medical profession has been just inundated with something that's totally brand new. But,
right.
But this is what you guys do. You've seen 14,000 COVID patients. This is your life.
Yeah. Now 17,000.
Well, 17,000.
It just it grows every day. But go ahead.
Well, I mean, I just wanted for our listeners to understand is like, I mean, we have people close to us that come and like, hey, our daughter has similar symptoms as Keegan. We're like, all right, stop what you're doing and go get your labs tested with covidlonghaulers.com, register, get an appointment. And the fight that a lot of people have, Dr. Patterson, is that they now got to go explain it to their general physician or their pediatrician or somebody to, and it's almost like, not that they're being shamed, but it's like people are ignorant to what is out there as an option, which is why I wanted to have you on this. Yeah. And since we spent so much ridiculous time and money and pain for our daughter, we're trying to shortcut this for people.
Right. And again, I think it's not a criticism. This is one of the most complicated diseases I've ever seen in 30 years of pathology. And, it's understandable. I think the one thing that, I am somewhat critical about is if you don't know, don't say that something doesn't work or something's not legitimate. Just pass it off. For instance, I may be, long COVID, our team may be a long COVID expert, but I go home, and my wife's shoulder's completely messed up. And I'm like, I don't know what's going on. That's not what I do. And I sometimes I feel like a fool because I don't know it because I'm a physician, but it's like orthopedics is not my thing, and I'm willing to pass that off or find the best possible physician to fix that. Yeah. But I certainly don't, poo-poo that some surgeon wants to do X, Y, and Z because I have no idea what works and what doesn't work. So I think it's just this general non-belief that for some reason, and I've noticed that in my 30 years of medicine, is that when anything new comes out, new publication, whatever, the first kind of reflex to something new coming out is, oh, I don't believe that, or that's not true, or that can't be true. And you almost feel like saying, okay, what do you got? We don't. But, we just, like I said, since I got back from China in January 2020, I literally have had my head down working 24/7 with very little time off, very little breaks. And yes, it is difficult when you see a rag publish something that is so completely untrue. Not to mention, very few people understand our process, which is we use precision diagnostics run by FDA and CLIA approved labs. We do telemedicine with all licensed, physicians. We make recommendations. We don't prescribe any drugs. We make recommendations in collaboration with their primary care physicians. Primary care physicians manage the patients. We continue to manage their immune system through diagnostics. And then we're just about to come out with our own ImmunoWatch, which will allow you to score symptoms and track some of the vitals, heart rate, O2, heart rate variability, et cetera, to be able to be informed about where you stand symptomatically as opposed to just, talking about it on a telemedicine. And then ultimately, we're going to control the drug so we can reduce the price of some of the drugs that we use and offer them as generics. So that's our business model, which is absolutely unique. There's really nothing like it. And anyone who thinks that they really understand the nuance of what that is, or they'll write articles without even talking to us, there's no possible way they could understand what and how we do things. So, but that's neither here nor there.
Yeah, exactly.
I think the important thing is getting a message out.
Yeah. So let's, I know we only have a short amount of time together, so I want to make sure I have a few specific questions that I wanted to tackle. So the S1 protein, and I wanted you to see if you can help, like when people ask, well, why is this happening? I thought, is it Dr. Osgood, when you were on the Dr. Drew show, which I thought was a great coupled interview, he explained, imagine you go to a street corner and you're going to get jumped by a bunch of bad guys. So you pull out your cell phone and you call in reinforcements to blow up the corner, right? And to save you. The problem is that the next day your cell phone calls 3 more people to go blow up the corner, but the threat is now gone, right? Which is the metaphor is the inflammation just keeps storming the body.
Yeah.
And the other metaphor or analogy on long haulers COVID, which I want you to clarify this, because this is me sharing these stories to people, is that you take your garbage bag, you stick it in a closet, you lock the closet, and then what happens is it starts rotting and spewing into the house, but nobody can go in and clean it out. So those are the 2 analogies I'm using to kind of explain long haul COVID in a very 101 basic level. So I'm going to pass it over to you to kind of explain why this is happening and clean up my analogies a little bit so I can help more people.
Yeah, I think that's a really good start. I think the long and short of it is there's these cells in the blood that are like, I think they're like viral garbage cans. I showed back in the 90s that in the early 2000s that we could infect these cells with HIV. Then I published a paper in 2009 showing that these cells contained actively replicating hepatitis C. And they have the ability, like Pac-Man, to kind of engulf foreign junk, garbage, if you will. And that's exactly what they're doing. Now, the problem lies that this one subset of these cells called non-classical monocytes, their sole role is to patrol blood vessels. And when they're bringing along S1 protein and we have evidence through some of the markers in our panel that, like soluble CD40 ligand and CCL5 and VEGF, that the blood vessels are inflamed. And they're inflamed because these cells bind to the blood vessels with that S1 protein and cause the inflammation. So what we're doing is two things.
Can I interrupt real quick? So the S1 protein is coming into the body through either SARS-CoV, the virus, or is it also being injected in when people are getting the vaccine?
Yes. And we have a paper ready to go that shows almost identical pathogenic mechanism where they have a very similar immune profile by AI. And we did isolate these cells and do very fancy mass spectrometry on these cells to show that they too contain the S1 protein months and months and months after injection or after infection. I mean, they're very, very similar. But our new classification scheme can actually sort through some of the subtle differences and correctly classify those. But yes, long and short of it. But what happens is these white blood cells, basically these dying respiratory cells with virus, they basically gobble them up, and then they contain the protein and maybe even some RNA which degrades, and then they continue to contain protein and express protein, and so that the immune system thinks the virus is still there, when in fact it's not. And then we did whole genome sequencing to determine that there's just RNA fragments. So there's a lot of studies that show, oh, we found RNA in this tissue, that tissue, in long COVID, and oh, it must be, continuous replication. Well, there's a big stretch between pieces of RNA being there and the ability to make a new viral particle, right? And that's what we're saying, is that they're using techniques that look for small fragments. And of course, we found small fragments. The good news is we did whole genome sequencing so that we could say these fragments aren't in an organization where they could create a new virus. So it's not replication competent. And we're continuing to do that work on tissue right now. But yes, that's the problem, is you have this huge garbage can, like that Pac-Man guy going around scooping up foreign stuff. And it's long-lived. And there's papers out in Lyme that show that the cell wall, the bacteria, is contained within the same cells. And that's spread all over the body. And that's probably the source of the Lyme inflammation and why they're responding to the same drugs that we're using for long COVID. So it's really fascinating how it's coming together. And for the first time, these very disparate conditions, fibromyalgia, chronic fatigue, post-Lyme and long COVID, we're bringing together through analysis of their immune profile and sophisticated statistics to show exactly what's going on, to classify them correctly, and to treat them appropriately.
Yeah. Do you mind, just in a few minutes left, going through like the protocol and treatments that or however you want to go through it, like what treatments are you finding are finding success? Where is there still room for opportunity? And then how could people reach out? That's probably my last three questions.
Yeah, no, it's what we basically did, and I think this new paper really defines it, is we figure out what cytokines are elevated or abnormal. And there was this brilliant paper last August in New England Journal of Medicine that did this for autoimmune diseases, lupus, rheumatoid arthritis, ulcerative colitis, etc. And what they did, and this is the source of this new paper that we're submitting in response to this paper, is they said all these autoimmune diseases affect different organs, but we're going to organize it by what cytokines they make, so-called cytokine hubs. With the strategy, and it was amazingly when this paper came out, I'm like, we're literally doing the same thing for these 4 related conditions. And that's why we're submitting this as a letter to respond to this article, which I think is brilliant. And the summary in the article was, we're going to use those specific cytokines. We have armamentarium of, say, 12 drugs that by now we know exactly which cytokines each drug brings down. So we get a panel back from a lab panel for a particular patient. We go through the lab panel and we say, oh, okay, these cytokines are elevated. This set of drugs will most likely work on this patient. So then we make the recommendation to their primary care physician that we think these sets of drugs, because of their mechanism, will work for this cytokine profile. Again, very similar to what was in New England Journal. And I think that's where we'll see improvement. And then as we go along, we continue to measure those cytokines. And when we bring them down, as we showed in the new paper, we bring them down, the symptom scores come down. And that was just so amazing when we first did the stats in this paper that just is out in preprint and we've submitted for peer review. It's incredible that this targeted precision cytokine approach has led to therapies that are working.
Yeah, our Lyme doctor, Dr. Casey Cummey, who you've met, is very excited because she's always had a feeling or a gut feeling that like there's got to be more of an immunological approach that could be used with Lyme, and you guys are discovering it. So Pretty awesome. Where would people go to sign up to get the initial labs and work with IncellDx if they want to?
Yep. So it's www.covidlonghaulers.com. We've now launched in the EU and the UK. We're in the early days of that. And then eventually we'll go to Mexico and South America. So we're expanding the program. Like I said, because of the way we do it, it's very virtual. And really lends itself to the current environment of virtual medicine and engagement. So I think, like I said, it travels well. So that's what we're busy doing right now.
Well, I know you guys are slammed and you've been generous with your time today. I'm gonna tell you that this is gonna be part one. I'm gonna bring you back on in 6 months, because I know we'll be able to share an update where Keegan's at, and hopefully send a lot. I already know I've sent people your way, and we're in so many, just for people listening, we're in so many COVID long hauler groups and line groups, and you see the desperateness on parents, and we're just really trying to get this message out. And I remember laying in bed with Nola before Keegan started your protocol. I was like, if this works, I will it'll be my personal mission to make sure that the entire world knows about Dr. Patterson and what they're doing. Because that's where we were at in our, the depths of despair when your child's sick. It's just unlike any other experience.
It really is in children, especially. I mean, it's just so poignant, what they're going through and where they can get to ultimately.
All right, awesome. Well, I'll let you go. Thanks, Dr. Bruce. We're always here to support you.
Pleasure. Thank you. Right. Appreciate it. Thank you.
Hey, it's Ed again. Hey, one last thing before you leave. First, I really appreciate you taking the time to listen to the show. If you love this show or this episode and know someone who can benefit, please copy it and share it with them. Also, if you can do me a favor and leave a quick review wherever you listen to these podcasts the most, whether it's Apple, Spotify, etc., it really will help us get the message out to more people. That's it. Thanks again, and make it a great day.